Schwartz. Dr. Alan Schwartz is a professor of nephrology in Philadelphia, and he is also president of the Hypertension Society and a great speaker, and he will teach us about hypertension. And because we talked about the ABC, I talked to you already about the A, and he is going to talk about the B. That is the new guideline for hypertension. And tomorrow you will have from Dr. Perloff. He hasn't come yet. There will be a great talk on that tomorrow. All right, Alan, nice having you here. I look forward for your talk. Thank you.
Thank you, Mahfoud. Oh, we have a loose battery on the floor. How do I get rid of this? Well, all right, we're ready. These are our learning objectives. We're going to recognize multiple guideline changes that have occurred since 2014. So my first question to you is, how many people in the audience were treating blood pressure elevation in 2014? Can I see a show of hands? How many people got confused in 2015? We're going to discuss if the same one blood pressure reading or goal can fit all. We're going to evaluate the patient who has stage 1, stage 2, or stage 3 hypertension severity. And we're going to plan the treatment for hypertension depending upon if it's primary or secondary. Does that make a difference? We're going to manage hypertension in CKD, chronic kidney disease, and in diabetes. And we're going to discuss the role of the renin-angiotensin-aldosterone system in hypertension. And we're going to plan for treatment with combination of medicines. I have no disclosures to make, and as one of my friends once said, darn it. I asked this question. As I came in today, I took a picture. And here is the picture. Does it matter? Does it depend on your point of view as to how you control blood pressure? So do you follow the JNC7, dated 2003? Do you follow the JNC8, 2014? Do you follow Sprint, 2015? What is AHA, ACC, ASH, ASN, ABC, et cetera, position on treating hypertension? Is this the end of the guidelines? Is this the beginning of the guidelines? Is this the end of the beginning? Only some will understand that. So I took this picture of a sphygmomanometer, and I asked the question, should the red numbers be moved? What systolic blood pressure are we striving to obtain? Are we looking for 120, 130, 140, 150? As we scan, we see some numbers are red. And we ask the question, what is age? What is diabetes? What is CKD? What is heart? What is race? Do they influence what is happening to blood pressure? Now, I must admit that as I went through the different communities in Pennsylvania, Delaware, and New Jersey, where I live most of the time, and I would go to the individual medical centers and the facilities for treatment, they were concerned. They were confused. They were disillusioned. There was a controversy that existed right under my eyes, I thought it was necessary that a paper should be written describing the controversies in hypertension and the treatment goals. So I wrote it. It's called The Complexities, Controversies, and Disagreements in Hypertension Treatment Goals. September 2016, Volume 10, in the Journal of the American Society of Hypertension. And this is what we said. Recent reports were intended to improve and simplify the management of hypertension. Instead, the opposite has occurred. Complexity, controversies, and disagreements in the treatment of hypertension noted in the last 4 years. From the JNC 7 to the JNC 8 to the JNC whatever the number is going to be. From 2013, 2014, sprint, to 2015, to 2016, to 2017. What is possible that the future would return to the past? These questions require discussion and hopefully a comprehensive resolution in our journals and national meetings. What blood pressure is too high? 160, 150, 140, 130, 120. What blood pressure is too low? 140, 130, 120, 110. Can too low be harmful? What time of day is referenced for blood pressure measurement? Should we take the blood pressure on awakening, morning, evening, bedtime, asleep? What posture is referenced? Supine, sitting, standing. What level of activity is referenced? Resting, walking, running, being on your computer, online, driving on the freeway. What medicines are recommended for CKD, diabetes, coronary artery disease, heart failure, stroke, TIAs, black versus non-black, gender, male versus female? What medicines are more or most effective with least or less adverse events at all ages? What is old? What is frail? I miss my friend Barry Madison, who wrote a paper very significantly indicating what is frail and what is old. What is intensive blood pressure goal versus standard blood pressure goal? Primary hypertension, CKD, diabetes mellitus, secondary. And I'm going to ask you to please compare the handheld bulb aneroid sphygmomanometer with the digitized manometer. And I'm going to ask this question. How many people in this audience on a regular, everyday basis use a digitized manometer? Wow. Hardly less than 10% are using a digitized manometer. I asked this question, how many people use an old-fashioned mercury manometer? 4. Well, what are we going to do? What are we going to use? And this paper was written. It was published in 2017, November the 13th. And I ask you to read it if you haven't, read it again if you have. The question is, can one guideline fit all? That is the question. It wasn't written by Shakespeare, Paul Welton et al. And all was a long list. Trying to get the opinions of all physicians, cardiologists, hypertensionologists, nephrologists, nurses, PAs, black versus white, men versus women. Can one guideline fit all? And this is what came up out of it. You look on this scale, and what you see is 130 over 80, almost all of the time in the right-hand column, almost all of the time except the occasion here and here. What these two point out perhaps is no clinical cardiovascular disease and 10-year arteriosclerotic cardiovascular disease risk score less than 10%. Alluding to the risk score of less than 10%, what does that mean? One can get an app for your phone, put it on your computer, the atherosclerosis risk calculator. The app taking into account the risk factors that were discussed earlier. Those involved in cardiovascular risk, what are they? You put in the age, the gender, the race, smoker, yes or no, systolic, diastolic BP, the cholesterol level, the HDL. Does the patient have diabetes, coronary artery disease, or heart failure? And you press enter. And the calculator gives you a percentage of risk as to whether or not this patient will have a cardiovascular disease event. Taking that into account, the recommendations have been stated according to that publication that is now barely a year and 3 months old. Redefining hypertension as a blood pressure greater than 130/80 and recommending starting antihypertensive drugs, therapy, based on the arteriosclerotic cardiovascular disease risk score of greater than 10%. And then we ask the question again, is this significant in terms of change from the JNC8 that you read back 4 or 5 years ago, or SPRINT that you read approximately 4 years ago? And we ask the question, will the new hypertension guidelines redefine the outcomes? So let's see if we don't give you any dizziness. You assess the patient's risk score. You determine a blood pressure that is called stage 1, 130 to 139, over 80 to 89, one or the other or both. And you call the patient stage 1 hypertension, recognizing that their arteriosclerotic cardiovascular disease risk calculator is less than 10% or equal to 10%. You start with healthy lifestyle recommendations already discussed: weight control and exercise, salt, everything else that we have to discuss. Healthy lifestyle and reassess in 3 to 6 months. If the risk is greater than 10%, or the patient has known clinical cardiovascular disease, diabetes, or chronic kidney disease, we recommend lifestyle changes and blood pressure lowering medication. And we start a medicine. We will call it medicine number 1. Reason: most patients will require 2 medicines. Medicine A is given. Reassess in 1 month for effectiveness of the med therapy. If the goal is met in 1 month, reassess in 3 to 6 months. I prefer to say 1 month according to ABS, Alan Bernard Schwartz. That's my name. If the goal is not met in 1 month, consider different medication. Continue monthly follow-up until control is achieved. We agree. ABS, dated in 2018. Pardon me. Use 2-drug combo. Since more than half the patients will require 2 drugs, you may ask the question, should I start with 2 drugs? But the recommendation is start with 1 and consider up titrating or add the second drug. What is the second drug? How to prescribe the second drug? Is it A plus D? A stands for ACE inhibitor or ARB. D stands for diuretic. Or is it A, ACE inhibitor or ARB, plus C, C stands for calcium channel blocker. We then ask the question, what happened to BB or beta blocker? Beta blocker was removed from the recommendation in this paper publication, November 2017. I would like to add, you use the beta blocker in stage 1 if it is indicated for a specific reason, AFib, heart rate control, for example, heart failure. We'll move to that. Stage 2, equal to or greater than 140 millimeters of mercury, or diastolic equal to or greater than 90. Obviously lifestyle, and here it is recommended that 2 drugs be started simultaneously. 2 different classes are used, A plus D or A plus C. You may ask the question, can they be started in 1 pill? To be discussed. Reassess in 1 month. Reassess in 3 to 6 months. Schwartz disagrees. Every month until we are certain what's going on. If the goal is not met after 1 month, consider different medications or titration of doses. So, add a 3rd drug. Now we have broken the alphabet again. A plus D plus C, but it's the same, A plus C plus D. We're giving an ACE inhibitor or an ARB plus a diuretic plus a calcium channel blocker. Can you prescribe a 3-drug package all in one? To be discussed. Uh-oh. How are you taking the blood pressure, by the way? Are you using the mercury manometer that I discussed earlier? Are you using the handheld bold sphygmo? Are you using the digital sphygmo? Think about that for a moment. The recommendations of last year, 2017, did not discuss the old stage 3. I prefer to use the old stage 3 hypertensive urgency. That is greater than 180 systolic or greater than 120 diastolic. So according to ABS, I prefer that there be a stage 3 written into your chart with a definition. Many of these patients are non-compliant. How do you check for compliance? You ask the patient, you do a blood level, you do a urine level, you call the pharmacist. When did the patient last get their prescription refilled? Are they utilizing all their pills in the package? Many of these patients are non-compliant. Be careful when you follow them. Reinstitute or intensify the drug therapy and treat the anxiety as applicable. Check the blood pressure and recheck the blood pressure. Rule out emergencies, especially in those at 180 over 120. Now, back to Sprint, or what shall we do with Sprint? As it was said, when we reviewed the data, I asked the question, where is 130? When Sprint was devised, it was devised to compare 140 with 120. Less than 140 actually achieved 134.6. Less than 120 actually achieved 121.5. The manometer was a sphygmo manometer with a digitized system, batteries for power. When compared with a bulb sphygmo, the digitized manometer in the study gave a 6.4 millimeter of mercury difference reading, lower than the handheld sphygmo manometer. Wow. Ask again the question, where is 130 in this study? It's not there. Consider the most recent publication, Brian Williams and Giuseppe Mancia. They talked about the 10 Commandments, published in 2018, the European Society of Cardiology, the European Society of Hypertension. I mentioned their findings for your consideration. They are complicated, but we will state. The definition, they say, is 140/90. That you want to treat at that level. The guidelines in the United States do not agree. We call for 130/80. This is the most recent publication. There will be confusion. There will be disagreement. There will be uncertainty. I prefer to recommend to you, read them for your education, but we will follow those recommendations that were recently published indicating 130/80. Recommending after lifestyle intervention, this interesting following, the seventh commandment, initiate therapy with two-drug combo. A question we asked a few moments ago. Can two drugs be safely started at the same time? It is recommended in the European study that two-drug combo be started. We may have a bit of hesitance based on adverse events. You would not know which drug of the two-drug combo caused the adverse event. Therefore, it is recommended by ABS that each drug be started independently and you add the second drug, and then you can combine them, but that is ABS. Notice the single pill strategy that I just discussed. Poor adherence, however, does benefit from single pill strategy. Those people who cannot remember to take a second pill, especially if they are different times of the day, will benefit by single pill. The algorithm that recommended the ACE inhibitor or the ARB combined with a calcium channel blocker or a thiazide or thiazide-like diuretic. So it is A plus C or A plus D. Three-drug combo, ACE inhibitor or ARB plus CCB plus thiazide. Again, the beta blockers were separated, looking for an indication, if specific indication, such as post-myocardial infarction, heart failure, reduced EF, or heart rate, looking at the patients, for example, with atrial fibrillation. The first drug, or certainly the second, would be a beta blocker. I want to show you this slide. The Annals of Internal Medicine, looking at a group of patients with chronic kidney disease, looking at the target of 140 versus 130 to 139 versus 120 to 129 versus less than 120. If one considered the benefit of the previous sprint study in which there was no 130 goal, consider here that group that was 120 to 129, or otherwise stated less than 130. You can hardly tell the difference between the less than 120 over 80 group. Consider the recommendation then that the 129 or thereabouts, less than 130, from a benefit standpoint, is just as good. Whoops. Uh-oh, I'm in trouble. Okay. So my conclusions, answering the question, the time-updated blood pressure study that we just showed you, it looks as if we can get to less than 130 systolic, the benefits will be similar to those of striving for 120, but not with the complications of adverse events, orthostasis, TIAs, AKI, that stands for acute kidney injury. Therefore, do not go less than 120 when you strive for 130 over 80. In the diabetic patient, looking at the benefit of recognizing that the patient has proteinuria, notice that when there is a decreased nephron mass, there is an increase in activation of angiotensin II in order to get an increase residual GFR from the remaining nephrons, and a result is proteinuria. More filtered protein, more protein escapes reabsorption. But in the process, more protein is reabsorbed, and the increased protein that is reabsorbed damages the cytoplasm of those cells of the tubules. As a result, there are inflammatory cytokines released, endothelin-1 and others, and they increase the fibroblastic proliferation. As the increase in the angiotensin system increases even further, there becomes a growth factor effect, and one sees more collagen, more glomerulosclerosis, and more fibrosis. Therefore, you must give the ACE inhibitor or the ARB in all patients who have diabetes and hypertension together. I remind you of the drug classification that was mentioned a few minutes ago, the SGLT2 inhibitors in diabetes. They allow a special benefit in addition to blood pressure control because of the reabsorption of glucose in the proximal tubule, as shown here, and osmotic diuresis results. Weight loss and blood pressure decline is noted within a short time, and the blood pressure will be, with this medication for blood sugar control, 6 to 8 millimeters of mercury lower than without it. In diabetics and in chronic kidney disease patients, select an ACE inhibitor or an ARB as drug number 1, calcium channel blocker or diuretic as drug number 2, and the other as drug number 3. Consider giving them together. For those patients with coronary heart disease, those patients with heart failure, those patients with stroke, we are still recognizing the 130/80 as the target for blood pressure management. In those patients who have coronary artery disease, a beta blocker may be considered along with the ACE inhibitor or ARB as double therapy. In those patients with heart failure, symptomatic, and an ARB or an ACE inhibitor plus a beta blocker, diuretic, and spironolactone. It is not unusual to find a patient with heart failure and hypertension to be on 4 drugs with a spironolactone addition. In those patients with a stroke history, you will be careful. You will consider that mention that we had earlier of 140/90 immediately, pardon me. With a stroke history, an ACE inhibitor or an ARB, and then the add-on therapy. Now, in someone who has had a recent myocardial infarction, you notice the J curve. You notice that the adverse event number is greater on the upswing and greater on the downswing of blood pressure. You strive to be in the safe area. A systolic of approximately 130, not exceeding 140. A diastolic somewhere in the vicinity of 80, 83.8 to be exact. In summary, the value of the renin-angiotensin-aldosterone system, angiotensinogen acted upon by renin, converting renin-angiotensin system to angiotensin 1. Next, remember, ACE activates through angiotensin 2, an ACE inhibitor would work there. Remember, the AT1 receptor antagonist would act there. Remember, either an ACE or an ARB, not both together, especially because of the potassium complications that would be a result. Remember, it is a full cycle, and one can get to the effect of angiotensinogen. So in summary, we're talking about an ACE or an ARB plus a diuretic, an ACE or an ARB plus a calcium channel blocker, or in step 3, all 3 drugs together. I consider that. We recommend, I do, A plus D and add on C. Others recommend A plus C and add on D. This particular study is interesting, and I summarize and finalize. Taking a 3-pill combination medicine shown in the orange part of the graph, the 3 pills or 3 medicines or polypill or combo pill, whatever you want to call it, has a better long-term systolic control rate and a better long-term diastolic control rate than telling the patient to take 3 separate pills during the day. Blood pressure should be taken often, especially in the elderly. Consider home blood pressure. Recognize that you will be able to detect whether or not there is dipping or whether or not there is no dipping in the nocturnal phase. There should be nocturnal dipping. Some patients lose their nocturnal dipping with long-standing hypertension. In the morning, there is a surge. We will refer to it as the AM surge. Patients lose the AM surge. The combination of loss of dipping and loss of the AM surge adds to the adverse effects of long-standing hypertension. How do you determine whether these are present or not? Home blood pressure monitoring is the answer. Therefore, I ask this question. In a 45-year-old white male with hypertension and CKD requiring 4 antihypertensive drugs to treat hypertension, serum creatinine 2.8, BUN 32, the electrolytes as shown, and hemoglobin as shown, what rule indicates a plan for time of day to administer antihypertensive medicines? A, at least one of the 4 medicines should be given at bedtime. B, all 4 meds at 7 a.m. C, all 4 meds should be taken at noon. D, all 4 meds at bedtime. And the answer is, at least 1 medicine should be taken at bedtime in order to get the blood pressure down. So in the end, is this the end of the beginning, or is this the beginning of the end? The beginning of the future of hypertension guidelines for specific patients has only just begun. Thank you very much.
Thank you, Alan.
I don't know what was happening there.
Okay, thank you, Alan. That's very fine presentation.